see here in the slide. So all the segments of the aorta, I'm sure you're aware of. So if you want to define aortic root, for example, I'm sure all of you know that the aortic root starts at the basal ring and ends at the sinotubular junction, and then the ascending aorta from sinotubular junction to the brachiocephalic or the innominate artery. The arches from this point to the left subclavian and so forth. So the descending thoracic and abdominal aorta, suprarenal and infrarenal. So all of these terms are important when talking about aortic disease, either dissection or aneurysm. But there's another classification. Do you know about the zone of aorta?
Yes.
Yeah. So what's zone 0?
So zone 0 from the aortic root until the base of the innominate artery.
Yeah.
Then zone 1 followed after that from the innominate artery to the left carotid. Then from left, this is 1, 2, from left carotid to the left subclavian. Behind the left subclavian, zone 3.
Yeah. So
I'm sorry, zone 4 after that also.
Yeah. So what's the importance of this zone?
It is important in management planning, especially in endovascular. So the feasibility of endovascular repair is dependent on the zone of these on this classification.
Yeah.
Especially, for example, zone 3, zone 4, and in some literature, zone 2 as well. Especially, we can use stenting in case and to close the left subclavian. However, in zone 1, we cannot, because that can lead to the stroke. In normal anatomical variation, of course.
Yeah. Okay. So so that's great. So I think you have to know all these nomenclature and the importance of it definitely during your exam. And I'm also sure that you're all familiar with these graphs. This is from the natural history of aortic aneurysm. So this graph here on the top left corner of the slide shows the incidence of aortic complication related to size of the aorta. So as you can see here, it's the complications start to increase at size 6 centimeter for the ascending aorta. So that's why this is the graph that all the guideline depends on the size where we intervene. On the bottom right side also, the graph shows the rate of complication related to the size of the aorta. And again, as you see, 6 or more has always a higher complication rate. This is the same here. It also shows not only the size that is the major role for deciding whether we intervene or not, but also the relation of the size to the size of the aorta to the patient himself, the size of the patient. So you can see here the sizes of the aorta and the body surface area. As you go up with the size and with smaller patient, you have higher risk for complication. So you have to keep this in mind always when you are deciding about an aortic aneurysm, about counseling a patient with aortic aneurysm for intervention or not. I think this table was taken from one of the IRAD paper. Okay, so let me ask you a question. The layers of the aorta, layers of any artery or of the aorta, can you define the dissection for me?
Dissection. تفضل حسين.
Dissection, it's separation of the intima and media resulting from tear of the intima.
طيب, what's the strongest layer in the blood vessel?
Adventitia.
Okay. And what is the pathology usually for patients with aortic aneurysm, degenerative aortic aneurysm?
Most likely increased blood pressure or related to connective tissue disease and thinning of the intima.
The histopathological changes.
Median necrosis.
إيش?
Cystic median necrosis.
Cystic median necrosis. That's also one of the classical question you might have in the written or oral exam. Okay, so a couple of slides from the guidelines. Those are from the, I think, from the European guideline, but more or less they're the same, similar. I think 90% similarity between the European and the AHA guideline. So the magic number is 5.5, صح?
Yes.
Yeah.
Yes.
So what are, can you list, Hussein, can you list the special circumstances, other than 5.5, when would you intervene for aorta per size?
Patient with connective tissue disease usually will go less by 0.5. So Marfan syndrome, we will intervene with 5 centimeter. If Marfan syndrome with positive history of family history of dissection or rupture, we will go to 4.5. Or if Marfan syndrome in young female, she is planning to get pregnant, we go up to 4. If Marfan syndrome going for other cardiac surgery, we go to 4.5. And bicuspid valve, it's same the regular population. 5.5 if going for other cardiac surgery is 4.5. If there is increase in the rate more than 0.5 per year, we have to intervene. And regardless of the size, if patient symptomatic or have complication, we have to intervene.
What kind of complication?
If patient with aneurysm develop ruptured or dissection or pseudoaneurysm.
Okay, let's say when he had acute event. Okay. How about Ehlers-Danlos syndrome?
It's less than the regular population. For the size, it's 5 and 4.5 if going for other surgery.
I think it's 4. Ehlers-Danlos.
Yeah. Yes. In many literature, yes, Hussein. In many literature, they go 4.5 and 4.
It's 4 if you are taking the inner dimension by the echo. If you are taking by CT, you take the whole dimension. It will be 4.4.
Yeah. Okay. So that's all covered. How about the relation of the aorta to the size, to the size of the patient? Is there any numbers you know about?
This score should be more than 3 in pediatric.
Okay.
There is a ratio, Hussein. I think the ratio of the sizing to the body surface area. I forget the ratio. Is it 1 point? I need to review that. There is ratio, Dr. Fahd.
Yeah, there's a ratio the size to the height.
To the height of the patient, yes.
To the height of the patient, yeah. That's from the AHA guideline. I also can't remember at the top of my head, but there is a ratio. I think it's 10 or something like that, because you take the height in millimeters, the size plus the height in centimeter. So there is a number. I can't remember it, to be honest. Okay, so let's say you have a patient who does have an aortic aneurysm, and it's ascending aortic aneurysm around 5.2. He has no history of family history of sudden death or aneurysm or dissection before, and this aneurysm was found to be was found incidentally during a chest X-ray that showed a widened mediastinum, and then led to a CT scan. He came to you for a consultation. What would you advise him?
So if the patient without any risk factor, and I need to have an echocardiography to check for the competence of the aortic valve, if the aortic valve...
Yeah, the valve is bicuspid, and there is a moderate aortic stenosis. The patient is asymptomatic.
Patient asymptomatic with moderate aortic stenosis and dilated aorta of 5.2. So I don't have here a class 1 indication to intervene with this patient, especially he's asymptomatic. I need to follow him closely, close follow up with him with a serial echo plus serial serial CT chest. If he reach 5.5 or develop severe aortic stenosis or AI, at that time he need to underwent surgical intervention.
Okay,
but there is no surgical intervention. I agree with you, but this patient
class 1.
Yeah, but this patient need medical intervention. All these patients should have controlled blood pressure and heart rate, regardless of if they met the criteria for surgery or not.
Yeah, of course. He need beta blocker. He need AC inhibitors, or medical management is consisting of one beta blocker to have a heart rate less than 60 or 60 to 70, and blood pressure less than 110. And also many study and even in the guideline, AC inhibitors and ARDs showing good result to prevent the complication of those patients for development of more dilatation of the aorta. Medical, yes.
Okay,
so I forgot to mention medical management.
So we agree, no surgical intervention, no need for surgical intervention, or no class 1 indication, and you start him on control his blood pressure, ARB, and beta blocker. What else?
Family screening. I need to do family screening on him because bicuspid aortic valve, there is association of, there is a family association, just to be sure. In his family, there is no also genetic testing. Sometimes patient with bicuspid aortic valve, they have some sort of genetics abnormality.
Okay, so
the other thing. The what?
كل العيلة يعني ولا مين؟
No, the first degree relative. I need to screen the first degree relative.
Male and female?
Male and female, yes.
Okay. What else?
Also, I need to check for aortic qualification in this patient because the association, there is a bicuspid aortic valve associated with aortic quark plus VSD, which is VSD can be can be discovered during echocardiography, and aortic warp also need to be investigated. So medical management. Okay. Medical, surgical, counseling, genetics, and family, and this is what I'm thinking now.
طيب any يعني lifestyle modification.
Of course, if the smoking is increasing the risk, very important to have a lifestyle modification, especially the smoking, because the smoking can lead to more dilatation, as it's in effect because it's affecting the elasticity of the aorta and interfering with the elastin, and he need to stop smoking to decrease the progression of aortic dilatation. If he's doing heavy lifting, I will advise him to stop that heavy lifting and just do regular exercising, swimming or running, because it's been shown in the study that heavy lifting can lead to aortic dissection because of the increasing pressure and shear stress and all that. And this is the most important, I think, two things in the lifestyle modification. Statin is not showing any improvement to. I mean, no solid evidence about using lower lipid lowering agents to improve the outcome in cases of connective tissue disease.
Okay, طيب, that's good. So weightlifting or exercise avoidance is important as well in those patients to decrease the rate and decrease the complication incidence as well. Okay, so that's all. That's a complete counseling for patients with aortic aneurysm. How would you follow this patient?
So initially, I need to do echo in the next 3 months, then 6 months, then 12 months. طبعا depend on the echo and CT result to see the progression of the expansion. Echo to check for the aortic disease, I mean for the aortic valve progression. CT scan to follow up the expansion rate of this patient. If it is increasing, at that time I need to intervene. I mean immediately. If not, after 3, 6, 12 months, then it could be annually.
So you're gonna do CT scan 3, 6, or 12 months?
Yes.
Okay. يعني هذا من الجايدلاين؟
The guideline, I didn't recall specific this question, but what I recall, first I need in the 3 months to have to know the progression of the disease. Maybe Hussein, you know better than this.
I think this number, Haytham, 3, 6, 1 year, then annually to follow the chronic dissection or follow after surgery. For patient with borderline sizes, we have to follow every 6 months. The other patient annually.
But to examine the progression, is it 3 or 6 months?
6 months.
I didn't 6 months. Okay, so it is my.
And the class 1 indication is to do echo for every patient who is having aortic aneurysms. And then after 1 year, if it is a smaller size or no risk factor, and after 6 months, if there is if it's size more than 5 centimeters, or there is risk of accelerated enlargement.
Echo ولا CT يا عثمان؟
Echo. Diagnosis is echo.
I think I think 3 months is an overkill. I agree with Hussein. 3, 6 and 3, 6 months and 1 year is for post surgery, post dissection. I would do 6 months to 1 year, depends on the patient and the risk and the size. Maybe at the beginning, maybe once every 6 months, just to make sure there is no progression, because the first time you see the patient, and then probably annually. Depends on the patient as well. So if the patient is, for example, very difficult hypertensive, or his hypertension is very difficult to control, or he didn't quit smoking, this is probably someone that you need to follow, or I will follow very closely. If a patient is very compliant, medically sound, and has no family history of risk factors, I'll probably follow him anyway. So you can use a guideline, but this is something important you have to consider and think about when you see those patients, right? Because I think when you're a practicing surgeon, you will be consulted for those patients, not just to operate, but you will to give your opinion, and then you should be responsible for those patients and their follow-up, right?
Yes.
Okay. So we were talking all about the ascending aneurysm. Let's just have a quick discussion about descending aneurysm dissection TVAR before we move forward to do some practicing cases. So any of you guys were involved in descending aneurysm service, or descending aorta service, or TVAR, or have you done during your training? Because I know most of the centers here are not, most of the cardiac surgery centers are not doing TVAR.
Yeah, we rotate with the vascular. I saw in specialist hospital a couple of them, and in university hospital, Dr. Turkey doing.
Also,
okay.
for me also, I've been exposed with the vascular surgery with the traumatic aortic dissection in the descending aorta, as well as TVAR for aneurysmal descending aorta.
I have been exposed with vascular only with descending.
And also in our hospital, we had a hybrid approach regarding cases with, there was 2 cases was done, hybrid approach, stenting cover of all arch plus descending, then deep branching, then we did a deep branching from the ascending to the neck vessels.
To the head vessels.
Okay, so
yes, sorry. عديها حسين.
Okay, so the procedure itself, TVAR, or has this principle, right? So whether it's for dissection, aneurysm, or traumatic aortic injury, right? So
yes.
are you aware, familiar, or can you list for me, when you see a patient, what are you looking for a patient who's going for TVAR? Or if you want to decide whether this patient is a candidate for TVAR or not, in general.
In cases of... In cases, we can classify it either it is dissection or aneurysm. In dissection, it is complicated or uncomplicated. Uncomplicated will go to medical therapy. Complicated...
No, this patient is going for TVAR, or he needs TVAR, regardless of the indication, right? The principle is almost the technical principle is almost the same across all pathologies, right?
Yes.
So that's what I'm talking about. You're looking at the CT of a patient with an aneurysm. With traumatic aortic injury and had pseudoaneurysm. So what are you looking for? Is he a candidate for TVAR or not? And how are you going to do it?
Okay, the most important things in the principle of TVAR is the landing zone. This is the main principle that they are looking for, that I need to have a landing zone proximally and distally, and the patient is, per guideline, the patient need not to have a connective tissue disorder. However, there is a series, and they are doing with a connective tissue disorder, TVAR, but stick to the guideline. It is not advised, and the landing zone, at least, if I'm not recall, if I'm not mistaken, 2 millimeter, at least, to have a landing zone, 2 or 3 millimeter.
Millimeter or
Sorry,
centimeter?
centimeter.
Yeah.
2 to 3 centimeter as a landing zone. Landing zone mean a healthy tissue, not aneurysmal tissue.
Yeah. So in the landing zone, other than the length, what do you look for?
The size of the aneurysm itself, that my stent can go through, and I can expand it. I didn't recall the number, the circumferential number, but there is a specific circumferential number in width of the aneurysm that's suitable for TVAR instead of open repair.
Less than 5.5.
Less than 5.5. Okay, thank you.
And also the angulation of the, sometimes in aneurysmal disease, the landing zone or the normal aorta will be at an angle because of the aneurysm. So all of these technical considerations you should keep in mind. Okay, so let's say you do have
tortuosity, yeah, also.
Tortuosity, yeah. And the axis itself.
Axis, yes.
Axis, you mean vascular axis or
vascular axis?
Yeah. So
because of the sheath.
Yeah, we'll come to that. I was talking about the tortuosity is the angulation that I was talking about. Unfortunately, I don't have slides for this. But sometimes when you have an aneurysm, because of the aneurysm, the aorta is going to be pushed down and up and deformed. So the normal part of the aorta will be coming out at a acute angle or 90-degree angle. Sometimes technically it's not possible to do to land a stent or a covered graft, sorry, in that area. So all of these you have to keep in mind. Okay, so what is the possible complication that can happen during TVAR procedure?
Ischemia, bleeding, ischemia from covering any part of the ascending or from the arch or descending aneurysm. That include covering the subclavian with most likely it's nothing will happen with the subclavian, but if we cover the carotid or the renal or major branches in the abdomen, it will lead to ischemia, perforation, and vascular injury. And if we cover long segment in the thoracic, that may lead to spinal cord ischemia and paralysis.
There is also one you forgot.
Stroke from embolization and MI.
One more, very, very important.
And stent leak or technical error.
Also dissection, retrograde
dissection. Yes, dissection.
Yeah. But what do you mean by stent leak?
There is different type. The most important one, it's
ايش اسمه صحيح؟
endoleaks.
Endoleak. Types of endoleak.
Type 1 at the proximal side, type 2 at distal side, type 3 through the feeding fizzles, type 4 through the graft manufacturing, type 5 due to oozing on the graft, and there is one more type.
Six
The one.
type, 5 types, sorry.
Yeah, there's one more.
Type 5 types. Type 1, I think, يعني, at the end. Type 1, you either have you have improper landing zone, or you didn't land the stent properly. So you have either proximal or distal part. There is no leak. There's no seal, so there is a leak. Type 2, I think, is when you have stent overlap. So sometimes when you put 2 stents, right? When you put 2 stents together, so you'll have between the stents the source of the leak. Or type 3, when you have the blood vessel. So this is a common scenario, I think, when you cover the left subclavian, right? When you cover the left subclavian in dissection or in traumatic injury, sometimes the left subclavian can cause endoleak for you. And how do we deal with that? If you have endoleak in a patient with aneurysm and the source is the left subclavian,
we can put if the subclavian, we have to bypass the subclavian and ligate the origin, or we can put coil or plug if the hand it's not dependent on the subclavian.
Yeah.
Unless
so you can
اتفضل.
You can plug it. You're actually going during the procedure and you're planning to cover the left subclavian. You covered it, but it's causing endoleak for you, صح? So
Yes.
you can just enter a procedure. In the same procedure, you can plug it. Okay, implants, plug, or coil. Usually, coil maybe is small for subclavian. So I think plug is the answer. Okay. Let's see. Yeah, those are the type here I have. So type 1, when you have type 1 is proximal or distal. Type 2 is the blood vessel. Type 3 is between the grafts. Type 4 is through the porosity of the graft, and type 5 is the unexplained. So you do have tension in the aneurysm, but there is no obvious source for leak. Okay, I'll show you a case now, and then we'll have a discussion.
How many cases, Dr. Fahad, so we can distribute it kindly?
Wallahi, one long case.
خلاص, so you choose among us, and then يعني one by one can go through the cases, the case itself. Yeah.
Second, sorry.
Dr. Fahd, can I ask while you are preparing the presentation?
تفضل.
If I have kink in the right coronary, right
أيوة.
coronary anastomosis, shall I revise this one, or should I put vein graft to the BDA?
يعني sorry يعني rephrase it.
I finish Bental procedure.
Okay,
Then
you've been down. Okay.
Then I discovered there is a problem in the right system.
أيوة.
Should I clamp after coming off bypass or during coming off bypass? Should I clamp again and revise the anastomosis, try to fix the anastomosis, or just put vein graft to BDA and that's enough?
Oh, I would revise the anastomosis. If the problem is very clear, is it dissection cares or is it an elective dental? Depends.
Dissection.
Dissection, I'll probably do a graft. I'll probably
Okay.
put a graft, and because maybe the coronary is dissected, maybe it's twist. You don't know, right?
Yes,
So,
we don't know.
يعني أنت you're coming off pump and you have inferior ischemia, let's say, or the right side is dilated or the RV is failing, صح? This is what
Yes.
you're talking about.
Yes.
Yeah, I'll probably do a graft, vein graft.
Okay.
Yeah. Okay.
Okay, thank you.
So this is a 55-year-old patient, hemodynamically stable. He was found to have type A dissection in his CT scan, you were called to review the patient and the CT, and then advise. Okay, so I'll show you the CT. شايفين الCT?
Yes.
Yes.
Okay. So there you go. I'm gonna scroll down. I'll scroll down. Okay. And مين موجود هنا؟ maybe عثمان. عثمان موجود؟
Yes. So his name is here.
أيوه. طيب مش موجود عثمان.
موجود.
عثمان موجود؟
موجود.
طيب يلا. So I'll scroll down the CT. Please يعني ask me to stop. I want you to read the CT for me and see يعني verbalize your finding.
Okay. CT scan cross-sectional area showing a dissection in the aorta extending from the proximal aorta up to the arch and one of the neck vessels with huge aneurysms.
Aneurysm where?
The ascending.
The ascending, okay.
And the dissection extending down to down and the mesenteric and renal. And extending up to the bifurcation and more to the left, also to the left iliac.
Okay. طيب, let's go back to the head vessels and we see the extension there.
Yeah, here it looks like it's extending into the this is the right column. The right common carotid. Okay.
I think it's in the phenomenant, yes. Yeah.
And sparing the two other vessels. The arch and the
Okay, from the CT scan, do you think that the dissection extending to the aortic root?
Can you go back? The root, yeah, I think it's extended. I need the other the axial picture. I think it's better for me to judge the root. But here also, I think it is reaching the root.
طيب, you need what? قلت axial, coronal?
Coronal section.
Coronal. Sorry, zoom in for you. You see it?
Yes. I think it's above the right, the right. So.
Okay. What else do you want to know on CT scan? Patient with acute aortic dissection.
The site of the intermaltier.
Yeah.
The dissection, I will see the site of the intermaltier, the extension of the disease, the involvement of the neck vessels, and also the distal extension. There is an involvement of the mesenteric and the renal vessels.
طيب.
And complication.
Complication, rupture, or pseudoaneurysms.
يعني I have to you think about it like this. You're يعني أنت at home on the phone and your resident is talking to you, or your specialist, or the radiologist, or the ER physician who's referring the case for you. You want to ask him specific question to know about the case more, يعني, because sometimes when you look at the CT scan, it's obvious for you. It's in front of you. You will pick it up. Major complication.
Where is the dissection flap? The size of the aneurysm, the involvement of the annulus of the aorta, and is it extending to the one of the coronaries, involving the right or the non, or even then the left, and the involvement of the ascending vessels. So
If it's acute or chronic.
ممتاز. أنت you mentioned all this. There's يعني I think there's two major finding or two major complication you have to ask about as well.
Acute or chronic?
احنا by presentation is acute.
Two things major, which is ischemic malperfusion in terms of ischemia, as well as pericardial effusion or tamponade, which is will let me rush to the OR to take, to the hospital to take this patient. I think this is the two important things: malperfusion plus tamponade.
Yeah, so pericardial effusion or effusion and around the heart, fluid around the heart, you have to know. You have to see actively look in and the CT scan وشيء ثاني كمان pleural effusion or hemothorax.
Yes.
Right. So those are two finding that's easy to pick from CT scan, and it's probably an alarming sign. صح؟
Yes.
The intimal tear, sometimes it's not easy to pick from CT scan, and it's not really going to change your management, right? You're going to take this patient to the OR, صح ولا لا?
Yes.
I'm going to take him to OR, but at least I will have in mind that where is the intimal tear, so I will do only supracoronary, or I will do pental for this patient. And also the involvement of the artery, so I do hemiarch, or I will have to be dealing with more complicated surgery.
Okay. We'll talk some details now about the intervention. Okay, so this patient, you're coming to the hospital to evaluate and probably take him to the OR. He developed a seizure. Okay.
Seizure. So I will be thinking about stroke, or there is an extension of the malperfusion to the head vessels.
Right. So he had CT brain, and there's a major intracerebral bleed.
And how is the patient looks? Is he in coma? Is he just seizures? Is he coming
He
off?
had seizure, and then he was intubated. Started to hemodynamically still stable. He was his level of consciousness decreased. Intubated, had the CT scan, and he has major intracerebral bleed. Are you going to take him to OR, or do you want to wait? What's your opinion now?
If there is an intracerebral bleed, I think I would wait for him. I would not.
How about the dissection?
I don't want to make a surgery for the dissection and there is brain dead.
And he's brain dead?
Well, there is major intracranial hemorrhage, so I'm doubting the benefit from the surgery.
طب لو ما كانت major, if it's small bleed?
Not sure.
Yeah, but with heparinization, it will increase.
Yeah. So what are you going to do, Bayan?
I will not take him for the OR. Or at least I'll get neurological consult from neurosurgery, maybe. But I will not take him for the OR.
Okay, neurosurgery came, so the patient told you, yes, there is a bleed. We'll have to wait. No anticoagulation. There's no intervention for the bleed. There's no major. There's no need for craniectomy or IVD. Just conservative management. You're not going to take him to Aorta?
No.
Okay. طب يعني what's your plan? Now you're the responsible surgeon.
I will make sure that his blood pressure is controlled.
Mm-hmm.
And nothing else to do, to be honest.
So, blood pressure control, right? So, how are you going to control the blood pressure?
Labetalol, if it's available.
Esmolol also is short-acting.
But
Okay.
patient with the intracranial bleed, I don't want to decrease his blood pressure much also.
Why? You want to decrease his blood pressure so he will not bleed more in the brain.
Yeah, no, but you need to perfuse the brain also.
This is unfortunately, and with this case, because stroke either ischemic or hemorrhagic stroke. Stroke per se is not a contraindication to take patients on for aortic dissection repair. However, in cases of hemorrhagic stroke, it is different story. It's been mentioned even in many literature that it can stop me from taking this patient to the operating room because of the risk of transformation. I need to have a detailed discussion with my colleague in neurologist about hemorrhagic transformation, and it's depend on the situation of the patient. If he's really stable and I can monitor him by decreasing DBDT and by beta blocker plus giving him after load reduction in the same time, in this case I can wait on him until the risk of more hemorrhagic transformation is decreased, then I will take him to the OR. But if it is really he needed the OR, I need to explain it to the family. But the morbidity and mortality for this specific scenario is very high. If I took him with a major bleed to the brain.
I think Haytham, ischemic stroke is not contraindication to take him to OR, but hemorrhagic stroke is that different story.
Yeah, this is what I said.
Well, I would try to persuade the neurosurgery to drain the hemorrhage if it's significant, and maybe that will give me a window to operate on this patient.
No, there is craniotomy. There is small series doing craniotomy showing some benefits, very, very limited numbers, but it's not that much. But even in the recent literature, taking patients with a hemorrhagic stroke is like a contraindication for repairing of aortic dissection, because mortality and morbidity is very high, as all you said. This is what I know, unless we miss something that during our reading, and Dr. Fahd maybe can elaborate more, but this is what personally I know.
No, so I think all what you've said, guys, is correct. So you just have to organize your thoughts now. This scenario is not common, obviously, but it's very difficult scenario. صح? It's يعني obviously patient is very sick, very high mortality and morbidity risk with both option. However, I think as a cardiac surgeon, you're going to be responsible to make those decisions, whether to take patient to OR or not take him to the OR. But when you say, I'm not going to operate, you have to still treat the patient, right?
Yes.
So يعني if you have a case like this in the exam, you have to have an answer prepared, all right? So what you've said is all correct. You just have to organize it. So this patient has a brain bleed, intracerebral bleed. There's usually very limited intervention can be done from neurosurgical point of view for those patients. يعني maybe they can put an intraventricular drain but this will not prevent increased bleeding during OR, and it depends on the site of the bleed itself, right? So the craniotomy as well, I don't think it will prevent major bleeding when you put the patient on heparin. The dissection progression is not going to stop the mortality from the dissection. We know, right? So you have to calculate all this in your mind. So what is the mortality for an acute dissection, acute type A dissection?
1% per hour for the 48 hours. That's equal to 75 to 80 in the first week.
Yeah, so maybe it's a little bit lower شوية than that, Hussein. There is a graph I was trying to find صراحة بس ما أدري وين راح. There's a graph for the mortality of dissection I wanted to show you, but this patient obviously now if you take him to OR, it's a very major. There's a very high risk of mortality because of the intracranial bleed, right? So you always weigh the risk and the benefit. So you want to wait, control blood pressure, admission to ICU, obviously keep him intubated. In this case, the patient was intubated. And how long do you wait?
I can take the number from the other guideline other than dissection, which is actually in effective endocarditis. In cases of hemorrhagic stroke, you need to wait 4 weeks.
Mm-hmm.
For this, then you repeat the CT to check.
Okay.
It's ideal for a week, but you can go after 2 weeks.
Yeah, you can go after 2 weeks.
Okay. But
yes, Thomas.
Any other opinion? 1 week, 2 weeks, 4 weeks, or?
I think it depends on his conscious level. If he regain conscious and there is no deficit.
Regain consciousness, Uthman. So what do you do?
I might take him as early as 1 or 2 weeks.
Why? طيب أصلاً إحنا we're waiting because of the risk of increased bleeding, right?
Yes.
So taking him earlier will increase the risk of bleeding.
Yes, I think 2 weeks.
Waiting for him, it will increase the risk of death from his dissection.
From the dissection, huh?
Yes,
actually,
from dissection.
If he passed the 2 weeks, that means he converted from acute aortic dissection to chronic aortic dissection. If those patients lives in the periods of the 2 weeks, 14 days, now he transferred from acute aortic dissection to chronic aortic dissection, and I need to have a CT to see the progression. And I'm not expert in reading. Okay, I can see the CT, but I think I need also opinion from my colleague in the neurologist to tell me about the risk of bleeding after 2 weeks. Then close follow-up or daily follow-up with rounding on the patient, with me, with the neurologist, ICU team, to determine the best time to take this patient.
Excellent.
But without clear evidence, I will not take him.
I think Haytham, the new classification, it's after 2 weeks it's subacute, after 2 months is chronic.
In the book, yes, in the book, this is the one in 2020, the one with the vascular cardiac surgery. They came up with a new classification, but the classic one after 14 days, if you go to the book, to the TRSA, the one I sent you yesterday, it is 14 days to convert it to chronic. Usually those patients, if they pull through the window of 14 days, they will be like a chronic dissection. There is a risk of rupture at any time, but the critical period is 48 hours.
Excellent. So that's the point. If you look at the graph of mortality from the IRAD literature for type A aortic dissection, you'll see that mortality is very high in the first 48 hours. That's the 1% per hour, right, for the presentation. And if you're out of this window, the mortality rate decrease for medically managed type A dissection. And here's the point. So if the patient is alive, to me, if the patient is alive 3 days after the presentation, that means you can wait somehow safely as long as you can for the brain bleed. So I think if you answer in the exam 2 to 4 weeks, you will be very safe, explaining all the literature behind it and the reasoning, depending mainly on the as you guys just mentioned now, the mortality rate for the dissection and the mentioning conversion from acute to chronic and so forth. So very difficult case, not an easy decision, but you'll have to know all the ins and outs of it, depend how to medically treat it, obviously, and always you have to mention your discussion with the neurosurgery or neurology colleague and the follow-up. Okay. Okay, so معلش, now let's go back to a normal dissection case. So Bayan.
Hello.
Okay, so let's say that this guy did not have the brain bleed. He was found to have the type A dissection on a CT scan when he was he was complaining of chest pain. The CT scan you saw was a type A dissection involving the ascending aorta all the way down to the bifurcation, and there was involvement in the right in the brachiocephalic artery as well. So you're taking this patient to the OR.
Okay. Is there echo findings or not yet? Or I'm going to do a TEE?
There's no echo yet. So you're taking him. You saw the patient, consent him for surgery. You're taking him for OR. So now you tell me, how are you going to conduct your surgery?
Okay. I'm going to start with the femoral cannulation.
لا قبل الفم كان لسه البيشنت ما نام. So
okay, I'm going to position the patient, ECG, radial art line, and both sides, and nasopharyngeal temperature, along with rectal temperature, and cerebral oxygenation. And I will ask for a TEE.
Okay.
And then I'm gonna start with my procedure. Prep and drape.
What do you wanna from TE? What answer are you looking for?
The involvement of the aortic valve, and if there's any region and wall abnormality. Actually, I should look at the ECG findings if there's any involvement of the coronary or not.
Okay, it's normal.
Which has not, it's normal. Okay, so I'm looking for the aortic valve, if there's any regurg. So I know if I'm gonna do a Bental versus an interposition graft. I'm gonna look at the region wall abnormality and That's it. And if any pericardial effusion, any rupture, that will help me.
Okay, so there's no effusion. The valve is competent. The aortic
Is
valve
the
is
sinuses involved or not?
the dissection is all the way down to the just above the right coronary.
Okay.
All right. So why do you want two radial line?
Because as you mentioned, the the innominate was involved. So basically, when I go on pump, the right side will be damped in the pressure line.
The right side will be damped.
Yeah.
So why
if
do you
I'm
need
flowing
the right?
if I'm flowing in the true lumen, because it's dissected in the innominate.
If it's dissected and you're expecting a problem, why do you need a line there?
Because it's our practice usually to have two lines.
Yeah. So يعني why? You can do femoral.
Yeah, but I'm gonna go through the right femoral, and the left femoral is also involved, so I'm not sure about the reading there. Come on. So it's gonna be the same issue.
Okay. So I think if the dissection is to the innominate, if the extension is to the innominate, just like our case here, your radial line on the right side is still going to be okay. If you have a pulse where you want to put the line, I think most likely your line wouldn't be okay, so no damping. The radial line usually for I would prefer to have one radial and one femoral line for a dissection case because of the length of the procedure. Radial line usually, or sometimes it will go on, the radial artery will go on spasm, and you'll not have a very consistent reading throughout the case, especially coming off bypass. So I would choose to do one radial, one femoral line. So you said you're gonna.
It's useful if in other cases, if you are planning to do antegrade cerebral perfusion.
Yeah, so that's my next question. Now the cannulation strategy, or so let's take يلا حسين انت since you have so what's your plan in terms of managing the cannulation and cardiopulmonary bypass in this patient?
This patient is dissected on the arch and descending, so I don't have the option of cannulate the arch, and he dissected the innominate, so I cannot cannulate there as well. So the best option for this patient will be femoral. I will review the CT and see which femoral is spared from the dissection or connect to the true lumen. I will do cut down for this patient and cannulate the femoral. Regarding the venous cannulation, I will do the dual stage atriocephal cannulation. I will put vent through the after on bypass. I will put vent through the right superior pulmonary vein, and this patient have severe regurg, right?
No.
There is no regurg. I will put the retrograde cardioplegia as well.
Okay.
If you allow me, Hussein.
تفضل.
Right. So this patient, if according to the case scenario, he's relatively stable. After he's stable, actually, not relatively stable. So after the line, need, as you mentioned, the two lines. Even you can use right, left, radial plus femoral. If he's stable, I will go axillary. I know there is. You said dissection reaching all over, which is type 1 DeBakey. However, right axillary, it is a good option, and I need to review in the CT that is not involved in the dissection. So I will
dissected.
Yeah, anomaly dissected. Yes, type 1 DeBakey. It's okay. Usually it came in the laser curvature, and you can cannulate axillary through, and you will be in the true lumen. The dissection usually spare. It will not go to the origin of the axillary artery. You get the point. Some cases, I was once with, once we have contraindication to cannulate axillary. Either you have dissection that reaching the origin of the axillary artery, one, or you have, I have two cases happen with me with two different consultants, dissection with a right aberrant subclavian. So there is no points to cannulate axillary at that time. So we cannulated femoral, but axillary for me, patient is stable. First, I will do the axillary cannulation. Then I will open the heart. Then I will look for the pericardium. After doing these two steps, if the pericardium is dense, or there is a pericardial effusion, I will just open a small, I will do small opening in the pericardium just to evacuate, evacuate any blood that in the pericardium, and I need to notify the anesthesiologist to be ready for any hypertensive crisis at this critical time. After that, doing either bicaval or just dual stage. If I'm doing, I will not go bicaval if I'm doing the just cannulating the right atrium. Then I will start my conducting my pump, and as the perfusionist to cool down. While he's cooling down, I will start to dissect around all the arch vessels.
دقيقة هيثم خلصت الحالة كلها دقيقة. Okay, so cannulation, we're talking about cannulation. So axillary, femoral, arch, innominate. As you guys all mentioned now, you're all correct. So whether you want to cannulate femoral or axillary, it's okay. The axillary cannulation in this case, I think, is reasonable. The dissection in the innominate is not a contraindication to cannulate the axillary because the axillary artery is usually spared and usually spared of dissection. And if you cannulate it, you're most likely going to perfuse the true lumen or both, the true and false lumen. So again, so if the patient is stable, I think the axillary cannulation is a good option. So why would you cannulate axillary and not femoral?
Because that will help me while I'm in circulatory arrest to do antegrade cerebral perfusion.
Yeah, so that's the advantage of axillary cannulation. So antegrade cerebral perfusion. So and also you avoid the disadvantage of femoral
perfusion.
Retrograde perfusion and all the neurological disadvantage that comes out with femoral cannulation. So what is the advantage of femoral cannulation?
Femoral cannulation
it's fast.
تفضل حسين.
تفضل هيثم.
Bayan, what's the advantage of femoral cannulation? You wanted to cannulate this patient femorally.
It is fast.
Mm-hmm.
It is fast to go femoral. And it's easy.
Yeah.
It's not complicated as the axillary.
Yeah. So that's the major advantage of femoral cannulation: fast and easy. You can go and pump very quick, and most of the surgeons are familiar with femoral cannulation more than axillary. Okay, so Haytham, you wanted to cannulate axillary. Can you take me through the process? Can you count, what are the layers that you're gonna find during your dissection till you reach the axillary artery?
So the axillary cannulation, first of all, I need to go expose the axillary artery at the sub infraclavicular incision. Then I will usually I will push the pectoralis major muscles, and after that I need to palpate under the. I will not cut the muscles. I will just taking the fascia, palpate to know the axillary artery. There is 3 parts of the axillary artery: 1, 2, and 3. Sorry, first part, second part, third part. I will go to the second part to avoid injury of brachial plexus, and I will use 8 millimeter Dacron. It can be used directly or with 8 millimeter Dacron graft. I will prefer to use an 8 millimeter Dacron graft to sew the axillary artery after controlling distal and proximal. Then I will open the artery and sew my graft directly to the artery. Then I will release the distal to see the blood flow. Then I will release the proximal. Then I will clamp my graft.
I think one more thing, Haytham, you have to give heparin before you occlude the artery.
Heparin just 5,000 to be given, not full dose heparin. But while dissecting, especially as that area is rich of, there is what they call it, rich of vessels. While dissecting, before, you are right, Hussein, before I will give 5,000 heparin, but not the full dose heparin.
Okay, so you said, I wanted you to count the layers. Yani skin, and then you will find
skin, and after the skin, the subcutaneous tissue, then the fascia. Then I will be faced with the pectoralis major. It will come. Then I will just push it laterally. Then in the second, because in the.
And what is your incision, Hussein? Haytham?
Okay, interclavicular muscle. Interclavicular bone, just below it in the first strip, in the middle. In the midpoint
of the clavicle. Yes.
Midpoint, yes, midpoint of the clavicle. Okay, just
middle third of the clavicle, let's say.
Middle third, yes.
Middle
third, you said? Yes. Middle third of the clavicle, yes.
That's what you want to do, صح?
Middle third of the clavicle, let me check. Yes, middle third.
Okay, so skin, subcutaneous tissue, pectoralis major.
Yes.
طيب ايش حتسوي في البيك ميجر كنت؟
I will just push it laterally.
كبير المصل.
Usually you split this one and push the pectoralis minor.
Yeah. The
pectoralis minor, yes.
Yeah. So the pick minor can be pushed. But the pick major usually either if your incision is in the mid clavicle, and it's a big muscle major part, I think you'll have to cut through it. Okay. So
okay, I want to review again.
So behind the muscle, what are you gonna find?
Usually, the first thing will come to me is a vein before the artery. Fat.
There's a lot of fat. After the muscle, there's the infraclavicular fat. Fat pad. Yes. There's a huge fat pad there. You will have to probably dissect and retract inferiorly until you will find the vein, and behind the vein you'll find the artery.
Yes, and I need to be just cautious for the brachial plexus. Sometimes while you are dissecting, you can see it, not to cause an injury to the brachial plexus.
Yeah, so there's So there's two approaches for axillary artery cannulation. You can stick to either of them. You have to know it. يعني the layers is a common question in the exam, also in the written exam. So you have to know, it's an anatomic question. So you can either do infraclavicular, your incision is in the middle third of the infraclavicular area, so 1 centimeter below the clavicle. Or there's another approach, which is the delto pectoral groove. Okay, it's a more lateral approach. The disadvantage of this approach is that you are closer to the brachial plexus, and there's more chance to for injury to the brachial plexus. The advantage is that it's easier in terms of getting quicker access to the axillary artery, because it's more superficial. The more lateral you go, the more superficial the artery is.
Yes.
Okay, so you can review that. There's many YouTube video actually على both approach. Very nice YouTube video you can find يعني 10 minutes usually around that. Okay, so we said then you give heparin, you sew grafts most likely, and then you can use it for antegrade cerebral perfusion during the pump, right? So that's arterial cannulation. The other option we said is femoral, right?
Yes.
And then the other option is you cannulate the arch. If the arch is free of dissection, you cannulate the ascending aorta with the ultrasound guide to the true lumen. It's very fancy approach. I think there was a discussion yesterday. I saw the discussion in the group this morning about this approach. But I think in my opinion is that this approach is for let's say if you are an aortic surgery center, okay, you have an echocardiographer, you do this you do a dissection 20 times a year or something like that, right? So you don't want to try this on your dissection that you do every 6 months. Agree?
Yes.
And then there's the transapical cannulation, right? So all these options you have to keep in your memorandum and be ready to use them. Maybe one day you will, but for the sake of the exam, you have to know the options at least, okay?
Okay.
All right, so talked about axillary cannulation, femoral cannulation, monitoring for those patients. So let's step back now again. If you have right radial artery and femoral line, let's say, and you're doing axillary dissection, axillary cannulation, you're covered because you're going to use the femoral line for your case. And you're going to use the femoral line throughout the case. The right radial is going to be used, but it's going to be damped while you clamped if you have only right radial, it's going to be damped when you clamp the artery, صح? When you clamp the artery to do dissection, so you have no pressure monitoring during the time you're doing your anastomosis. And you're not going to have pressure monitoring when you clamp during your time of circuit rest and doing your antegrade cerebral perfusion. So that's why you have to have another line, femoral or left radial. If you have only left-sided, either femoral or left radial artery, you're not going to have the pressure monitoring during your antegrade cerebral perfusion. We will talk about in a few minutes now. Okay. Cerebral oximetry, transesophageal echo, and bladder and nasopharyngeal temperature, all important. You need the cerebral oximetry, obviously, to have information about brain silence activity before you start your circ arrest, and the bladder and nasopharyngeal temperature to monitor your hypothermia. Which one is more reliable?
Nasopharyngeal.
ليه؟
It's closer to the brain, and the bladder will be. It's not that reliable with the circulatory arrest, after circulatory arrest.
So there's a reason that both are used, Hussein, I think.
Yeah, bladder, because this is a core temperature. When you're doing your cooling to reach a circulatory arrest, you need to use the bladder. Nasopharyngeal, it's used because it's near the brain, the tympanic membrane. So at that time, you need to use a nasopharyngeal to monitor the temperature of the brain. But for the core body temperature is from the bladder.
Yeah, that's my approach. I will, for example, when you go, if I want to cool down, the nasopharyngeal usually will go down first.
Faster, yes.
Will go down faster because it's closer to the cold blood, obviously, and the bladder will take time. So for the circ arrest, I will wait to be safe. I will wait for the bladder to be at a lower at the target temperature. And also during rewarming, I will wait for the bladder to be at the target temperature before trying to come off, because it indicates the core body temperature most likely. Okay. So now we cannulated right axillary in this case. Haytham, you talked. You open the sternum, open the pericardium with no fusion, double stage venous cannula, and retrograde cardioplegia. Right?
Yes, I can do that.
Okay, so initiate cardiopulmonary bypass and you start cooling. What's your target temperature?
So the target temperature, if I'm using antegrade cerebral perfusion, 20 to 24.
Okay.
Before doing the circulatory arrest. 20. My answer is 20.
أيوة.
My answer is 20. Okay. Not 20, 24, 20.
طيب ليش مو 18 هيثم؟
18, I have antegrade cerebral perfusion. As much as I go down with the temperature, as much much complication that can happen because of you know I'm sorry, Sayyidina Muhammad, coagulopathy and acid-base shift and all that. 20 for me, I will go with 20. I'm not expert to do moderate hypothermia, so I will just go for 20.
Saying you're gonna have different answer.
Yeah, I will go for 18 because some time before circ arrest, of course we have to take time before on 18 Celsius before go circulatory arrest, but I'm not sure the temperature will not increase during that time more than 20. So I will have margin zone of 2 or 3 Celsius. And it will give me more circ arrest on 18.
But you have antegrade.
Yeah. Uthman.
Yes.
Do you have do you know the difference, or what's the difference between moderate, mild, moderate, and deep hypothermia?
Deep hypothermic psychiatric arrest usually will be less than 20. If it is ranging
will moderate
moderate up to
28.
28 or 30.
mild 28 34. Here's did you شوف slide?
Yes, I'm looking at the slide.
Okay, so I think for the sake of the exam, and I will say 18 for the sake of the exam. Okay, stick to the safest number. This is it's written in all the books. Deep hypothermic arrest 18. Most of the surgeon is يعني expecting, I think, the resident to say 18 to be safe. Even if you have axillary cannulation, you don't know if you're going to be able to do. Let's say that yes, the innominate is dissected, you saw it in the CT scan, but you have trouble, right, during the circle rest, and you can't perfuse the brain, right?
Or incomplete
so
circle of Willis.
Yeah, incomplete circle of Willis. You are right.
Or incomplete circle of Willis, but this is what's all about. Okay, during dissection, during the exam, you have to do the safest thing. Yeah.
Okay.
So I would say 18 and use my anti-gray cerebral perfusion if possible. Okay, so you started the pump. You started cooling. What do you do while waiting for cooling?
You dissect around the ascending. Of course, you examine the ascending. You see them extension of the hematoma, if there is hematoma, or the size of the ascending, and you start to dissect around the ascending gently, and and you prepare your quadriplegia.
Quadriplegia antegrade, retrograde is in already.
So dissecting all the arch vessels, as Hassan mentioned, and it's prefer also to go around it and put a vessel loop on it in case if I need to use it later. And also I need to keep venting of the heart through right superior pulmonary vein. I will insert a vent there, because while cooling the patient, he can fibrillate, and that can lead to distension. And I need to have a safe measure for that as well.
Yeah.
And then I will wait until I reach my target temperature, which is 18.
So you don't clamp the aorta, arrest the heart?
If the heart starts to fibrillate, at that time I will clamp the aorta in the middle of the ascending aorta and start the cardioplegia, then open the aorta and give also ostial cardioplegia through the ostium, examining the valve. If the cooling still is ongoing and need time, I will work on my proximal anastomosis to reconstruct proximally before the distal, if I'm not reaching the desired temperature that I want.
Well, what's the disadvantage of clamping the aorta?
Ischemic time.
No, before.
No, it may increase the dissection.
Yes, it may increase the dissection, and the good thing is you just go and clamp it on the middle of the ascending aorta, not at the level of the innominate vein, sorry, innominate artery, because that being mentioned, it will increase the pressure, especially in the femoral cannulation, and can lead to progression of the dissection.
Right. So, and I think for the exam as well, if you have a dissection case, for the sake of the exam again, I'll try not to clamp the aorta. So طيب أنا بس سؤالي لك هيثم معليش قبل لا.
تفضل.
Why يعني أنت why did you clamp the aorta when the heart was start to fibrillate? يعني if
no
you
need.
want.
I will just open, no need to clamp the aorta at that time. If the heart starts to fibrillate, I just can, because fibrillation, distension, I have the venting, the vent that I use, so I will just vent the heart.
Yeah, you don't have to clamp.
Yes, I don't have to clamp.
Yeah, so again, so for the sake of the exam, I will not say clamping aorta. I think classical teaching usually is you don't clamp a dissected aorta. You circle rest before you you circle rest to open the aorta. You don't clamp it.
Yes.
Regardless of the extension, doctor, if there is a clear area of normal ascending aorta, I cannot clamp it.
لا, if there is, well, the case is obvious, yes. But classical aortic type A aortic dissection, the classical teaching or old-fashioned teaching, I think, is not to clamp the aorta, and it's safe. You wait till the patient is cool, and then you circle rest. You open the aorta. You start your retrograde cardioplegia at that time, and then you start your work on the distal part. After you finish your distal part, you start rewarming, and during rewarming, you finish with the proximal part. Whatever you need to do with the root, or you construct your sinotubular junction anastomosis. Okay.
Okay.
Okay, thank you.
So, Dr. Fahd, usually when you are doing Bental and in dissection, you will start with the distal anastomosis.
So, because of the fact that I'm not clamping the aorta, you'll have to start with the distal anastomosis, صح?
صح.
That's the only reason. If you're clamping, which I advise you guys not to clamp in the exam, okay? In the exam, don't say clamp. No, you can start with the proximal. If you clamp the aorta, arrest the heart, you start proximal, wait for the cooling, and sometimes it takes time.
And how you size the? I think sizing will be difficult for the Bental.
Why?
You size before you did. How you size?
What do you mean? Size the aortic valve?
No. Sizing the graft.
You're doing a Bental?
Yes.
It depends on the valve.
Yes.
It depends. You're doing mechanical composite graft or bio root, or I'll use the valve sizer to see the annulus. And
no, sorry, I meant the length of the graft.
The length. Okay. So if I'm doing a Bental and hemi-arch, most likely I'll do 2 grafts.
Mm-hmm.
Okay.
Mm-hmm.
If it's just ascending aorta, if there's no hemi-arch, then it's easy. It's easier to size. If you're doing hemi-arch, I'll most likely do 2 grafts. Yeah, distal, then proximal, then graft to graft.
Okay.
واضح؟
انت سألك حسين, is it because when you do the proximal first you just want to be sure you are not short or long? This is your question?
Yeah, what I see in the practice, we are usually doing the proximal first, and then you easy to cut the graft at the end when you are fashioning it. But when you are doing the proximal, you cannot, if it's long, you cannot cut the graft on the bental. You have cut it on the middle.
No, you just because I saw both techniques. So, but I think Dr. Fahd is here. Why I'm answering?
لا بس أنا ماني فاهم. I don't. Maybe I'm not understanding your question, حسين.
هو يقصد بعد ما تسوي البروكسيمال يكون لونج او شورت الجراف, فكيف يجيب اللينث تبعه مضبوط. I think this is your question. This is what I understand.
أي يعني أنت لما تسوي البنتال من البروكسيمال أول وتحط الكورونري, بعدين الجرافت طويل تقدر تقصه من أي مكان
صح
عشان تسوي الديستال. بس لو سويته الأذر واي عندك فالف نهاية الجرافت, لو كان سويته قصير أو طويل شوي ما تقدر تقصه من النهاية, لازم ترجع تقصه من النص.
So you start with distal يعني.
With distal.
Okay, طيب.
I think I understand what you're saying. So let me. So now we're talking not a dissection case. Any bental ascending aorta, صح?
Yes.
If you're doing a bental, okay, most likely you're gonna make your graft short, okay? So you're comfortable doing your coronary anastomosis, okay? And then sewing the graft in, يعني finishing your proximal part.
Okay.
Right? يعني أنا صراحة I've never seen a bental hemi-arch, يعني you go all the way with it to the hemi-arch with one graft. I haven't seen it. I haven't done it. I don't do it. I'll usually use 2 grafts. حتى لو بديت بالproximal part. You get my point? يعني حتى لو بديت بالproximal part, I don't use the same graft to go all the way to the arch. Because in the arch I'll most likely use another size, and to help me with measuring the length as well. Okay. Now, if you're doing only ascending aorta or only bental, or you're just changing the roots, then it's a different story and it's easier. You can start with the bental proximally, and then you just pull your graft and measure it, and then do your distal anastomosis. Then you'll have only 2 anastomoses, distal and proximal.
Okay, that makes sense. So I will do the distal, then I will do the proximal regardless of the sizing. Then I'll adjust the sizing according to the 2 grafts together.
Yes, and dissection, that's what I would do, because now you're not gonna clamp the aorta, right? So you can't do any work on the proximal part, on the roots, until your circle rest. And when you circle rest, open the aorta, you want to finish your distal part to resume your circulation as soon as possible. You get it?
Yes.
Okay.
Yes.
Okay, so now during circle rest, or before you circle rest, what question you want to ask other than the temperature? So you reached 18 degrees. How are you going to conduct your circle rest?
If I have an EEG I will wait for EEG silence.
Okay, so you have that's good.
And I will keep calling at least 10 to I would say 30 minutes to ensure also after reaching the 80 degree.
Okay.
To make sure that I'm the universal calling of the brain.
Okay.
Then I will drain the patient and open the aorta.
Ice on the brain or ice on the head, صح?
Yes.
Ice on the head. There's some evidence that also a dose of
steroid methylprednisolone.
ايش؟ ما اسمعك عثمان، صوتك شوية صدى فيه.
الانترنت يروح يجي. dose of corticosteroid.
ايوه corticosteroid, propofol. I don't know the strong evidence about it, but some anesthetists like to use it maybe for protection.
And mannitol as well.
And mannitol. Okay, so you drain the patient and open the aorta. How are you going to manage your antegrade cerebral perfusion? What's your instruction to the perfusionist?
Antegrade cerebral perfusion. I will keep the flow about 10 ml per kg per minute, cold temperature. That's it, I think. You want?
You open the aorta, صح?
Yeah.
And you open the aorta, you're keeping flow 10 ml per kg. So let's say 1 liter. Where is all this blood going?
I'm putting the antegrade where in the nominate.
We're already axillary cannulated.
Axillary. I have to clamp the nominate from its origin, so it will be antegrade cerebral perfusion.
Okay, so you clamp the innominate.
The blood will come back from the venous system, the IVCs, you see.
No, you clamp the innominate, صح?
Yeah, I clamp the innominate and the yes, I clamp the innominate.
Okay, you clamp the innominate, you perfuse 10 ml per kg. What do you monitor for during circle rest?
The pressure.
The pressures and the color of the blood coming back.
Color coming back from where?
From the antegrade cerebral perfusion.
Where is it coming back?
This is for the retrograde, not for that.
The saturation in the brain.
Yeah, so you monitor the saturation in the brain, right and left.
Yes. Just to be sure, there is an antegrade, what they call it, unilateral, and both of them need to be on the same saturation number. If one is dropped than the other, or if there is a drop, that means that I have a problem in the antegrade cerebral perfusion, or in one side, as Hussein mentioned, that incomplete circle of Willis. At that time, I need to intervene either to put another cannula, because the innominate left carotid and I have a left carotid that I snare. I can use a retrograde cannula to put it, to use both the axillary plus the left common carotid artery for antegrade perfusion. If there is a dropping in the oxygen saturation, a difference between left and right.
Yeah. So if there is a drop, there's no blood coming back from the left carotid. You consider adding another cannula. What else do you monitor for other than the oxygenation? The blood pressure, the pressure.
The pressure
Should be around 60 to 80, not more than this.
Where? Pressure where?
In the right arterial line.
The right arterial line. So that's one of the major points. And why do you need an arterial right radial line?
And
okay,
oxygenation in the left and the right hand as well.
Oxygenation the right hand. يعني pulse oximetry قصدك?
Yes.
Yeah, a pulse oximetry is going to tell you that there is flow. What's the disadvantage of this? We didn't mention. There's one disadvantage if we have longer or high flow for small patients.
Maybe you increase the flow on the right hand or cause ischemia in the right hand.
Yeah, you increase the flow. في حاجة اسمها overflow or over circulation to the right hand. It gets swollen sometimes. It's one of the complications that can happen. Very rare though. Okay, so you did your circle rest now with the adjunct anterograde cerebral perfusion. You open the aorta, you're inspecting your aortic arch. What do you look for?
You look for the false and true lumen, the tear. You inspect the aortic valve and coronaries, orientation and any dissection there, and you're looking for other tears, and you examine the sinotubular junction.
Okay.
Also in the arch is important to see if the tear is reaching the ostium of the arch vessels, one, or the arch vessels is aneurysmal, or is there a secondary tear in the arch?
Yes.
Okay, so what will make you decide what kind of arch replacement you will do?
It's depend on if it is aneurysmal or not more than 4.5, the arch diameter. If it is aneurysmal, unfortunately at that time, this patient need complete arch, or there is the primary tear. Actually, it is in the arch, or all the three vessels of the ostium of the three arch vessels is dissected. At that time, تفضل.
احنا من CT scan كان الانومات is dissected, and now you open, you don't see a tear in the arch. It's circumferentially dissected, but there is no tear, intimal tear. So what do you do?
Just hemi-arch at the level of ligamentum arteriosum, at that level to obliterate, and that's it, nothing more.
Good. Okay. All right, so let's go down now to the, so you finish your anastomosis, you finish your circle rest, start back the circulation slowly, de-air, clamp the graft, and now you want to do your proximal part. Let's talk about the proximal part of the procedure. So what do you look for? Bayan. You're examining the aortic root. بيان شكلها مو في. طيب حسين.
You examine the orientation and presence or absence of the dissection and the coronaries, and you examine the aortic valve and sinuses.
So what
but in this case, I will replace the aortic valve. because it's there is severe regurg and the sinuses it's dilated, right?
انت مصر انه في severe regurg. ما في severe regurg.
With sinuses.
طيب يعني okay, what would make you do a bental versus supracoronary graft?
The size of the sinotubular junction and the sinuses and the aortic valve.
Okay.
Or involvement of the coronary with dissection.
Yeah, or if the dissection is going
extended to the
if
to the root.
dissection is extending beyond the annulus, or there is a dilated root more than 4.5 centimeter, or there is a history of connective tissue disorder, I will replace it. I will do a bental rather than supracoronary.
Okay. All right, I think we covered that.
We replace if there is connective tissue disease.
If there is connective tissue, if the patient's marfan, I think I will consider doing a bental.
And bicuspid?
Bicuspid, maybe, depends on the valve.
So in marfan, it's regardless, even if the valve functioning.
Because if the valve is functioning, most likely the root is going to be dilated. Most likely, so you'll have lower threshold of replacing the root.
Mm-hmm.
Okay, so other than antegrade, do you know about retrograde cerebral perfusion?
Yes.
Yes.
Can you explain how to conduct it?
You put the the cannula in the high in the SVC, and you snare, and you run with pressure around 40s, and flow will be around 400 ml per minute.
Yeah,
and you
5
watch
ml per kg.
roughly will be around 400 ml per minute.
Yeah.
I'm not sure. It's 0.5 Haytham per kilogram per minute.
5 ml per kg per minute to antegrade 10 to 15.
Okay. So half of it.
And what pressure you want?
The CVB should be not more than 20. It's ideally around 15, but not more than 20.
You monitor the CVP. It's going to be higher because you're flowing there, so it's not. It's going to be higher than 15.
It's around 40 the pressure.
What's the advantage of the retrograde?
You wash the debris on the brain, and you the evidence of that, you will see the dark bloods coming from the major neck fizzles.
Yeah, and you cool, so it keeps the brain cool actually. Yeah, that's the effect of it. Okay. So the goal of dissection, usually after you do all this, you always have to keep in your mind that you want to do the safest procedure. You get the patient alive. So no fancy valve sparing, I think, or arch, complete arch repair or replacement if it's not needed. You want to do a quick, safe procedure and bring the patient alive. That's the goal of your surgery. After that, we talked about monitoring those, following those patients with CT scan 1, 3, 6 or 6 months, and then annually afterward. The patient, if they have this patient, as you saw in the CT scan, they do have a dissection that extends all the way down to the bifurcation. So all of this dissection still has to be monitored. The prognosis of it is sometimes the false lumen. If you direct the flow to the true lumen with your surgery, the false lumen sometime will thrombose and will be resolved. But most of the time there is another re-entry tear that will keep flowing the false lumen. So that's why we need to monitor those patients, because some of them will have a chronic type B dissection that will continue to grow and maybe are amenable for complications. So they might need another intervention down in the future, whether it's TVAR or open thoracoabdominal aortic replacement and so forth. So monitoring those patients is still very important. So the dissection surgery is only the first part of the treatment. Okay, any question, guys?
So, Dr. Fahd, in the exam, for the sake of the exam, let's say it is not connective tissue disorder, nothing, but it is, the root is the valve is okay. Otherwise, everything need to be replaced. So in the exam, I will say Bental. If they ask me, of course I'm not expert to do valve sparing. Even I saw it multiple times, but I think it's need my opinion. I need to do a fellowship on it because it's tricky a little bit. So in the exam, I will say Bental, even if the valve is competent. Then if they ask me if there is other option that can be done, then I can explain that I'm not expert, but there is a valve sparing, David, Yaqub, 1, 2, 3, then I can go for what is the valve sparing, right?
Absolutely. And plus, even if you have fellowship and valve sparing, I think you want to start doing it first in elective cases, not in dissection. So you can add that to the answer.
Do we?
You're right.
Do we? تفضل دكتور فهد, sorry.
You mention it. You always have to mention it. You have to know the steps of the valve sparing, where to put the stitches, how to size the graft, what's the advantage, disadvantage of reimplantation versus remodeling. All of these you have to know. But how to, when to do it, how to do it as well, you have to know. But this is my answer, will be in the exam, as you just mentioned. I will do a Bental and in real life as well. If I have a dissection, I will not do valve sparing for the dissection. Okay, I'll do a Bental because again, your goal is to take the patient alive out of the OR, unless you are the aortic surgeon or in an aortic center or very comfortable with valve sparing surgery, have done it multiple times or on regular basis on elective cases, then you think you can help the patient, then yes.
Even in the expert hand, do we do Yaqub in these cases? We are just doing David, right?
If you resect all the disease aorta, you still can do Yaqub. Why not?
But you will not address the dilatation of the annulus and Yaqub.
It depends.
Still will be regard.
It depends on why you're doing it, Hussein. If you're doing it just because the sinuses are dissected, there is no annular dilatation, you can do it, or you can add a ring to the aortic annulus or a piece of the graft. So technically, there is no contraindication. but it's not the dissection that's telling you, because it's a dissection, you do reimplantation, not remodeling.
Okay.
It's the other reason, right? If the patient is marfan and you want to do reimplantation, not remodeling, that's the reason, not because it's dissected.
Mm-hmm.
Any question?
طيب دكتور فهد عندي سؤال بس مو للأورال للام سي كيو. Patient, they did for him David procedure, and after they finished, they discovered there is moderate to severe regurg. So what's the plan after that? To take everything out and do Bental, or I can technically just replace the valve inside the graft?
I think you can replace the valve.
أنا قريتها في يعني في كتاب they recommend replacing the valve بس ما اقتنعت فيها theoretically.
No, you can replace the valve. Why not? Because you still have the annulus, right? The aortic valve annulus is still there. The valve, you just take the leaflet out and put the valve suture. It's easier than taking the whole thing down. Yeah.
Other question not related to dissection, in cases of patient came left main and non-STEMI to the hospital, left main, not critical anatomy. What is the proper time to take him for cabbage? Because I have discussed even this with Hussein regarding left main. There is different school, and there is surgeon, they will just next day they will take the patient to the operation, and the same night they will take patient in the operation. And the question is in the guideline, what is the proper timing if there's no critical anatomy? I mean, no indication for taking him urgently, and he's a stable left main or 3-vessel disease.
The guideline is very clear regarding emergency cabbages, صح?
Yes, very clear.
Emergency cabbage, يعني ongoing ischemia, whether ST changes, chest pain, or the cardiogenic shock, mechanical complication of MI. Those are the emergency cabbage guidelines. There is no other reason you have to go take the patient to the OR in the middle of the night. صح? Anywhere in the guideline and the textbook. We do this sometimes for left main. على قولتك critical anatomy. This is based on your eye. Based on your eye interpretation of the angiography, صح?
Yes.
There's no reason, يعني there's no evidence behind this. Although it's done, there's no evidence behind it because you don't know how long this left main has been there.
Yes.
صح? So أنا from school that I wait as much as I can.
Yeah, the question, I have to wait 5 days until the clopidogrel or whatever antiplatelet he was on is off, like 5 days, 7 days, then I will operate, or do I can discharge the patient and after 1 month? Because we have a discussion specifically to this point. What is the proper timing? He's stable now, no chest pain, nothing.
Yeah, no. So NSTEMI, revascularization for NSTEMI, usually depends on the patient. You risk stratify the patient. And most of the patient, because of diabetic hypertensive, most of them, you will do them in the same admission.
Okay.
If it's a left main, I will do it in the same admission as well. I will not discharge the patient.
Okay, if the examiner tell me he's stable and he want to go home, So what is the maximum period I can wait? Because we have this discussion with one in our first day and we came up that it is 1 month that I can discharge him, then bring him after 1 month. But in the exam, when I'm faced with this, then Hussein said in the guideline, it's been mentioned, it's 1 month, then we review the guideline.
Haytham,
Yes.
your question was patient with STEMI.
Okay, let's say
And
patient stable. Let's say stable coronary artery.
خليني أقول لك دقيقة. Your question was patient with STEMI. They manage him, and then his left main, they send him for surgery. When you will operate on him? The other question can critical left main 19. Your patient was 70%. The other patient was 99%. We answered that 99%. He will go for urgent. He will not leave the hospital before the surgery. The 70%, taking in consideration his STEMI, we will give him period to rest. And if we can wait for him for 2-3 weeks, if he's stable, we can do it. Otherwise, if he want to go out of the hospital, our period will be less than 1 month to bring him back because he's left main.
Yeah, why 1 month? And this is my question. Why
Because
I have to wait?
STEMI, صح؟ STEMI?
No, let's say yes.
STEMI with 70%, not critical.
Yeah, STEMI, ST elevation, ST elevation, MI, يعني, there is a graft for the mortality, operative mortality after transmyocardial infarction. And I think if you read the book, some book will say 4 weeks, some book will say 4 to 6 weeks. And there is another period where some book will say 72 hours if you want to operate. If not, then you wait for 6 weeks. Okay, I think that's where the answer comes from.
And Lawrence, it's mentioned, it's if you want to operate with period of 6 hours, or wait for after 2 weeks or 1 week, 7 days, more than 7 days.
More than 7 days.
But
yeah,
the longer it's better. If it's 2 weeks, it will be.
Yeah, the longer is better.
بس هيثم دكتور هيثم يسأل إنه هل هذا هيثم يسأل إنه stable left main أقدر أأخره أكثر من شهر ولا guideline إنه لازم قبل شهر؟
Yeah, you can, and again, you have to always weigh the risk and benefit. يعني the left main هذا not in STEMI. He presented, let's say electively, okay? Let's say electively. And he had not elective, sorry, he had angina, and he went to the cath lab, has the left main, and was presented to you. You weigh the benefit, the risk and benefit of waiting versus doing him, right? If there is no risk of doing him early, then why not? If the patient had MI, transmyocardial infarction, then you know that you're operating those guys in a critical period, then you wait.
Mm-hmm.
Okay, yeah, that's the idea.
Do we have, Haytham, do we have maximum time to wait, or it's open, or it's judgmental call?
No, there's an article, I think. تفضل دكتور.
I think for coronary artery disease, most of our cases, most of our cases, they're not very elective. And I wouldn't wait when a patient who has coronary artery disease indicated for revascularization for 6 months or something like that. I'll try to book him the earliest, within 1 to 3 months maximum.
Yeah, clear. And there is one study showing this patient with left LAD stenosis, and if you wait, I think annual annual incidence, they found it's, I think, 8% to have MI, stable coronary artery disease.
Yeah.
Well, thank you. It just was a little bit confusion discussion between me and Hussein yesterday. I told him tomorrow we'll bring it in the group. It's better to have an expert opinion.
Yeah. الله يعطيك العافية. بس I think it's زي ما قلت لك it's not في الجايدلاين it's not very clear.
Yes.
But what's clear is that the emergency cabbage, يعني taking patient overnight, the guideline is very clear on that. Very clear if the patient had transmyocardial infarction that you wait. صح? This is very clear.
Yeah.
Everyone agrees on it. Wait for 2, 4, 6 weeks. Depends on the source you're reading from. So if you stick to that, that's fine. يعني if every other case, there's no right or wrong answer. You can bring the discussion forward to the patient, between you and the patient and the examiner, and you as long as you have a justification to what you're saying, I think you'll be safe.
Okay.
Okay. All right. أنا معليش والله هذا الأورتيك دايسكشن الأنيوريزم ما كنت مرتب له أبدا. Hopefully we have يعني a good discussion. I think we touch point on the major point that يعني can come in the exam hopefully. Otherwise you can يعني extend on your reading. If you have any question you can come back to me anytime. We can يعني try to find an answer إن شاء الله.
إن شاء الله.
في حاجة ما تكلمت عليها صراحة كان نفسي يعني maybe you should just read about it, the neuroprotection for descending aorta. So again an important topic, maybe oral, maybe written. So neuroprotection, spinal cord, spinal drain, and what's your when is it high risk for paraplegia, and for operative thoracoabdominal aneurysm surgery, what technique you can do to avoid or decrease the incidence of paraplegia post-op.
Okay.